those lines.
Yeah. Yeah, I sent me a ton of stuff yesterday.
Good morning, everybody. I'm going to introduce first the lectureship. This is the Leslie Rudolph Lectureship in Surgery. Dr. Rudolph, we've heard his bio. He was appointed by Dr. Moeller as Assistant Professor of Surgery at UVA in 1963 and advanced through the ranks to full professorship in 1972. While he was here, he contributed much towards organizing the emergency room, which at UVA was very early in having formal emergency departments, developed the clinical program in kidney transplantation, and conducted research relating to whole organ preservation. The Rudolph Lectureship today will be delivered by Dr. Tracy Wang. She is Professor of Surgery and Vice Chair of Strategic and Professional Development in Milwaukee. She leads the department's Career Advancement and Professional Training and Surgery course, Captains. Dr. Wang completed her residency at Long Island Jewish Medical Center and then entered endocrine surgery at Yale University. She has published over 150 peer-reviewed manuscripts and book chapters. She is editor on the Journal Surgery, World Journal Surgery, and editorial board, as well as other journals and associate editorships as well. She's the Central Surgical Association's representative to the ACS Board of Governors. She's the chair of the Society of University Surgeons Jedi Committee, past executive on the Executive Council for the International Association of Endocrine Surgeons, past treasurer of the AAES, My Home Society. She's also secretary-elect of the AAES Foundation, as well as being past president of the Society of Asian American Surgeons. Dr. Wang has clearly built programs, built a career, has been very successful, is very well respected by all who know her, always a crowd of people around her at the AES benefiting from her guidance as well as her wisdom. So I'm sure she's going to give us some useful information about her work she's done and share that with us now. Thank you, Dr. Wang.
Good morning, everybody. Thanks, Phil, for those really kind words. So thank you for inviting me to be here today. It's nice to see some familiar faces and old friends and former trainees in the audience. So I'm going to talk a little bit about, So I have no financial disclosures to give. I do want to, again, acknowledge that this is the Dr. Rudolph lecture, and in reading his biography, it struck me that he was born in Pelham, which is not, while he started his life there, it's also where I started my medical career as a student at Albert Einstein, which is not so far from Pelham. So it's interesting how, if you look for it, there's lots of things that intertwine us. And in reading and trying to understand a little bit more about how he built the transplant program here, hopefully my talk today touches a little bit on some of the aspects of clinical program building, no matter what our specialty is. And then I just want to acknowledge and thank Phil and Alan Foy. I think Alan's feeling a little under the weather, for inviting me here. Again, it's nice when you think about our academic careers, how it brings us to know people from across the country. And this is a picture at the 2021 SAS meeting when Alan assumed the presidency of SAS. And if I can just take a moment, I would like to acknowledge one of our residents, Emmanuel Ababrezi. So he graduated from UVA as a class of 2020 for medical school before he came to NCW. He had finished 3 clinical years and was in his second year of research with our pediatric surgeons. Some of you may remember Emmanuel, but I wanted to acknowledge the connection between our 2 institutions. And for those of you who don't know, Emmanuel passed about a week and a half ago. So it's been a really sad time for all of us, and I just wanted to acknowledge his connection to UVA as well. And perhaps we can just take a moment of silence to remember Emmanuel. Thank you. What I would like to talk about today is what was in my title as dogmas in surgery, specifically endocrine surgery, since that's what I practice. And I think if you even thinking about this morning's M&M when we had conversations about do we give octreotide for Kyle leaks, or do we do this or that for various clinical scenarios, some of those things are just things that we have been taught or thought of, and we don't know why we do them all the time. We just know that that's something we might be able to do. And there are often hard to prove or disprove any utility for, but we sometimes try them because why not? And that's what has always happened in the field that we might practice. So what I'd like to talk about is describing a clinical research path to define some of these things that maybe we've always been taught to do, define new clinical protocols, and specifically around what we've done at MCW over the course of my time there, the postoperative management of patients after total thyroidectomy and the perioperative management of patients in patients who are undergoing adrenalectomy for hypercortisolism. And then maybe think about, especially for the residents and students out there for whom clinical research might feel really daunting, how can you ask a single question about our clinical practices, why we do it, and is there any different way to do it? Is there a better way or a different way? And can we challenge ourselves to think about that stuff for things we take for granted in our clinical practices? And then lastly, I'm just going to touch on how some of these, single questions can lead to, similar to what Dr. Smith mentioned, and how we can build an academic career through clinical program building and publishing what we do on a daily basis. So what is a dogma? So a dogma is in the dictionary, a principle or set of principles laid down by authority as incontrovertibly true, or a fixed, especially religious belief or set of beliefs that people are expected to accept without any doubt. And if you think about it, that goes very against the idea of evidence-based research, right? If you think about the etymology of the word, it's from late Latin and even from Greek, where dogma was opinion, and then I don't know how to pronounce this, dokein was seem good or think. So how do we get from an etymology of something seeming to be good or thinking about something to things that are fixed or incontrovertibly true? And so I think, that's an interesting question. I don't know the answer to that, but it does lead to some of the things that we just passed down in surgical time. I remember, and I'm going to talk about thyroidectomy. When I was a fellow, we had to get calcium levels every morning, and we had to circle them on, because there were written charts. We had to circle them on the side of the chart for our attending to know, and it just seemed like one of those things, like, why are we doing this? So what about thyroidectomy? So as you guys know, the most common complication following total thyroidectomy is hypocalcemia due to inadvertent devascularization or resection, inadvertent resection of the parathyroid gland. And it can be transient in up to 40% of patients or permanent in hopefully single-digit numbers of patients. And as you can tell, this is an interrupted picture. I don't know if it's showing as well. It can often be hard to see. And this one is showing right at the tip of the thyroid. So if you're not looking for it, you can see how easily it can be accidentally resected. So protocols for the postoperative management to prevent symptomatic hypocalcemia, which is the one thing we are most concerned about, have always been highly variable. So you can routinely supplement patients with calcium and or calcitriol, or you can give selective supplementation based on peri or postoperative calcium and or parathyroid hormone levels. And if you think about what are the benefits to that, calcium Tums, you can buy Tums by the boatload at Costco. It's really inexpensive, as opposed to thinking about should we order lab tests and make people do that. And the published literature that existed when I started looking at this really varied on the definition of hypocalcemia and the ability to monitor and document outpatient symptoms. So, if you say they're hypocalcemic because you check their calcium level or because they call it symptoms, you really have to have some baseline for which you can set standard protocols. So coming from when I was a lot of my work in this started when I was an early career faculty member, circling calcium levels on the side of pieces of paper. How do we change? How do we think about changing what has always been done? And moving from where I was training in Connecticut to Milwaukee, where Stu Wilson, who had been an endocrine surgeon and faculty at MCW for about 40 years before I got there, and so there are lots of things that he did that that have always been done at MCW, and thinking about how do we change some of the needles. And that can be daunting. So this is a picture from about almost 6 years ago. And some friends and I decided we were going to climb Kilimanjaro. And it was a little bit snowier and icier than we anticipated. And we got to this point about 16,000 feet up where it said challenge spot. And I was like, what has the rest of this hike been? But this was the view at the challenge spot, and it was not exactly what I was looking forward to on that day. So how do we do that? So we have to take one step at a time, right? So one of the big things, and when I talk with residents, I tell this to them, sometimes when you're asking a question, you have to know what exists already, right? So you have to do some sort of a literature. Sometimes it helps to write some sort of clinical review so that you can wrap your head around what exists in the literature. And so that's some of the work that I did with my mentors as faculty. So we wrote a review paper, and this was early in my career. And then with the data set that we had at MCW, we started looking at some of these questions. So we had a slew of data. We had a great database. So we're getting all these parathyroid hormone levels. What can we do with them to help better define what we were doing with our patients in the perioperative period? So we looked at, with one of our residents at that time, the value of PTH levels in whether or not patients needed long-term supplementation, and then a cost of utility analysis that I did with my mentors at Yale. And then one of the things we next did was to then, this was a study with one of the first studies where we looked and we realized that serum calcium levels were not a good predictor of whether or not patients needed long-term calcitriol, which is activated vitamin D for hypoparathyroidism. And that really our PTH levels were the best predictor of whether they were going to need that. So then that led to, in combination with this cost analysis, saying, okay, but it seems like routine supplementation is slightly more cost effective at a global level if you believe some of these cost utility analyses. So it got to the point where it's, well, what did we know? We knew that there's no standard protocol for postoperative supplementation. There's no standard definition of hypocalcemia in the literature, whether you define it as biochemical or symptomatic. And we were discovering at our institution that calcium wasn't the best predictor of who had long-term hypoparathyroidism, even though calcium was a lab that we were getting all the time in every patient that we operated on. And what didn't we know at that time? Well, we didn't know why get labs at all if routine supplementation might be more cost effective. We didn't know which patients were truly symptomatic because we were just sending everybody home on calcium and telling them to call us if they felt like the calcium wasn't really helping them and they were getting tingly. And then we actually don't know who is following their discharge instructions, right? So you see them back in clinic and they're like, oh, it's tingly, but I didn't take calcium. Or they're taking calcium and they're still tingly, and you still have no idea whether or not, what they were telling you was accurate. So that led to the idea that maybe we needed to do some sort of prospective study on this and really figure out what we could answer with this question. So I sat down and I kind of made up the protocol based on some of the data that we had. This was our initial protocol. And in the red box, what was really changing for us was after total thyroidectomy, we weren't giving them routine supplementation, which some of my senior partners gave me a lot of side eye about. And then we monitored and got labs on them on post-op morning one. And we were most keeping most of our patients at that time in the hospital, and also truly trying to assess their symptoms. And we came up with a plan, a randomization plan. So based on your PTH level, using thresholds of 5 and 10, you were either randomized to get calcium and calcitriol, or if your PTH was greater than 10, to be sent home with no supplementation at all. And so these were the results of our study. This was done over a decade ago. And what we found was that most of our patients, so 78% of them, had a PTH over that threshold, which we were saying did not need any supplementation. And when we looked at those patients, about 10% of them had documented transient symptoms. So maybe they called the office and said, hey, I'm having some tingling. And, we told them, well, hey, if you're feeling it, take some calcium, but none of them needed it routinely. And of the patients with that more worrisome PTH less than 10, about half did report symptoms. But again, almost all of those patients at the time could be managed as outpatients and with oral supplementation. So very few needed any additional management, really minimizing our ED visits and the need for IV calcium. And there was no predictors of who had a PTH less than 10. And then when we wanted to look also not just at what the PTH might tell us about needing supplementation, but whether or not they were really needing that routine supplementation, as I mentioned. And what we found out was very few patients, if you had a PTH less than 10, needed that routine supplementation, which was really helpful to us as we were thinking about this protocol. So then our next steps for this. So this was the first paper, and Ashley Ko, who's now an endocrine surgeon, presented it at the AAES meeting. The next step was then, well, there's a lot of data in the literature that looked at that 4-hour PTH mark. And again, this was around the time when people were also being a little bit more thoughtful about who needed to stay in the hospital and what patients might we be able to get home. So having a 4-hour PTH seemed appealing because we watched them a little bit after surgery anyway to make sure they didn't have any tumors. So we then created a protocol where we were getting a single PTH 4 hours after surgery, and then we still did our post-op day 1, so we could have some benchmark for comparison. And so what we saw here, and you can see in the red box, but for the patients who had a 4-hour PTH greater than 10, the most important thing was that by the next morning, their PTH was still greater than 10. So none of them slid backwards into a PTH less than 10 where we might accidentally discharge them without needing supplementation, when maybe they were high risk for hypopara, hypocalcemia post-op. So this was, again, an important part of our threshold, but our protocol about how we can simplify it and maybe have some wiggle room about who we could discharge patients on. And so that was really important, that the ability of a 4-hour PTH and post-op day 1 PTH to predict their need for calcium supplementation was similar. And so we refined our algorithm a little bit more. And this is still the current algorithm that we use. So we do a completion or total thyroidectomy. We obtain a single PTH level 4 hours after surgery. We get that back in about an hour and a half in our lab. And if it's greater than 10, whether or not they're staying overnight or they go home, nobody gets any other labs. If it's greater than 10, we don't send them home with calcium. About 5 years after we published that, we decided that maybe it was a good time to make sure that what we were doing was still accurate. So we always have anecdotal reports, but you have to kind of go back to your data and say, okay, did we just make something up and we're just masking things that are more worrisome because we're sticking to our protocol or what we now think is our new dogma around it. So we had 591 patients. Again, about 75%, 76% here had a PTH greater than 10. So those metrics were holding. And what we found was that we had a little bit more concern in that middle group, that PTH 5 to 10 group, in terms of who was symptomatic and asymptomatic. And this is a group that we had sort of left. They went home on calcium. Whether or not we added vitamin D was a little bit more surgeon specific. And so based on this, we were able to say, hey, these patients probably need a little bit more aggressive management post-op to make sure they're not getting hypocalcemic or symptomatic. And so now we're a little bit more, we sent almost all of them home on calcitriol. And that 10 to 15 group, they just need a little bit more monitoring. So we're just more mindful to make sure that they get an extra post-op phone call or that our nurses are following up with them after surgery. And we have a much lower threshold if they're having any symptoms to just have them go to a lab and make sure that everything's okay with them. So this was a nice way of sort of over the arc of almost 10 years, evaluating what we were doing, setting up a protocol, proving that it worked, and then reevaluating our data and continuing to prove that it worked. And again, we haven't looked at this data in a long time, so to some degree, you say, okay, well, that was a great study. What does that do for you guys? Well, none of this was funded. I'm not sure we could have gotten funding, maybe a small seed grant from our institution to do some of this. But one of the things it did lead to was allowing a body of work to be created. And how did this help? So think about what's next. Are we going to just rest on our laurels and say, well, we don't ever have to really worry about our protocols anymore? One of the things it did allow us to do was take, a body of work we did with these little parathyroid glands. And over the past decade, around the time when we were doing these studies, a group at Vanderbilt was looking at parathyroid autofluorescence. And what they realized was that parathyroid glands emit near-infrared autofluorescence. And again, and Carmen Solorzano gives a great talk on this. This was born of a research resident who said, what is going on with these parathyroid glands? What can we do around this? So similar ideas, right? From a single question that has now led to this whole field of work in parathyroid autofluorescence. And so this is a PTI machine. It's one of the ways that one of the companies that you can measure a parathyroid gland. So it's a single machine using a probe-based device. So you don't have to inject anything. And what they found was that the PTI correctly identified the absence of parathyroid compared to visualization by an expert surgeon in 97% of patients, and then also correctly identified parathyroid tissue compared to histology in 93% of patients. And this was one of their early studies looking at the use of autofluorescence in identifying parathyroid glands, both for parathyroid surgery, but also during the course of total thyroidectomy. And so Carmen Solorzano and Colleen Kiernan launched a study that looked at the experience of senior surgeons versus early career surgeons in identifying parathyroid tissue and whether or not the PTI device was more or less helpful for a senior surgeon or an early career surgeon. And they did this as a multi-site study. And so because we've had this body of work, Carmen knew that we had a tremendous data set and that we were really attuned and we could provide this data. She invited us to be a site for the study. And so this was something that was able to be funded through our clinical trials office and through her R grant that she shared with their scientists at Vanderbilt. And so then we were able to participate in this study. And so we participated. It ended up being, there was a whole bunch of IRB COVID-related issues, as you can imagine. So it ended up being a single-arm study, a single surgeon study in just the thyroidectomy arm. They did a thyroidectomy and a parathyroidectomy arm. But over the course of the year, we enrolled 80 patients into our study. And this was allowed us in a different way to follow up on some of our previous work. And so based on this, we had about, again, 70-75% of patients in that PTH greater than 10 mark. And then kind of allowed us to look at who resolved, who had transient hypoparathyroidism, who had long-term hypoparathyroidism. And again, our numbers are roughly the same over this time course. So it was a different way for us to reevaluate some of the work that we had done for a long time at our institution, which was really helpful, and also get some funding and enroll some patients in our clinical trials. I'm going to shift gears a little bit, then to now talk about some of the work we've done around adrenalectomy and the perioperative management of patients with adrenal adrenal specific hypercortisolism. So as you mostly know, hypercortisolism is the sustained exposure to supraphysiologic levels of glucocorticoids. And this can be ACTH dependent, so either from a pituitary adenoma or ectopic ACTH, for which you might recommend bilateral adrenalectomy if their disease is refractory, or adrenal dependent or ACTH independent disease, often due to adrenal adenoma, adrenal hyperplasia, or adrenal cortical carcinoma, in which usually a unilateral adrenalectomy would be recommended. And hypercortisolism in the typical form is, what we all learned in medical school with mood phases, buffalo hump, osteoporosis, truncal obesity, with primary causes of excess mortality because of cardiovascular disease, venous thrombosis, and infection. And we know that restoring a eucortisol state can have clinical and biochemical improvements. One of the things I'm not going to talk about today is this spectrum of mild autonomous cortisol secretion, where really I think most of the patients that we're seeing now do not necessarily come with these classical stigmata of Cushing, but do have some of the other metabolic consequences like hypertension and diabetes without being so overtly Cushingoid. So in the perioperative period, when we think about patients with hypercortisolism, we know that they're at higher risk for venous thromboembolism. And so there is reports of increased coagulability for refractor surgery. And we know that there's a need for both glucocorticoid and mineralocorticoid replacement after bilateral adrenalectomy. We also know that there is a risk of secondary adrenal insufficiency after unilateral adrenalectomy due to suppression of the HPA axis and or atrophy of the contralateral adrenal glands. And most institutions have long required routine peri and postoperative glucocorticoid supplement replacement. So if you brought a patient to the OR, you were going to do their adrenal for hypercortisolism, they got stress dose steroids, and then they got steroids all through the peri and postoperative periods. And when we started looking at this with our endocrinologists, and there was a systematic review published about a decade ago, this systematic review said, well, 86% of patients had postoperative adrenal insufficiency. But again, similar to the varying definitions of hypocalcemia that existed, if you actually look at these studies, they define postoperative adrenal insufficiency as initiation of postoperative glucocorticoids. And what we also knew was that everybody was just routinely giving them. So we weren't really assessing what the state was and who needed it. So in these guidelines from the Endocrine Society about a decade ago, as I mentioned, they state that we recommend follow-up morning cortisol and or ACTH stimulation tests to assess recovery of the HPA axis in patients with at least one intact adrenal gland, assuming there are no contraindications. And recommend continuing glucocorticoids when that response is normal. And we know that it can take up to 18 months to recover function of their HPA axis. So typically people were discharged on steroids, and then every 3 months they were having their HPA axis restored. And I think one of the things that was important to highlight is they wanted to discontinue the glucocorticoids when the response was normal. But that led to the question of, can we refrain from starting glucocorticoids in the postoperative period if their initial response is normal as well? So we worked with our endocrinologists and came up with a protocol for this. And so what we did was said, okay, if you are having a unilateral adrenalectomy for adrenal-dependent hypercortisolism, and we did primary alpha-patients with a control group, what we did was on the morning of post-op day 1, we did a cosentropin stimulation test. So they did not get stress dose steroids at the time of their surgery, and they were not started on glucocorticoids in the immediate post-op period. And then we did this cosentropin stim test. And so in our pilot study, this was if their basal cortisol was greater than 5 or they had an appropriate stimulated cortisol and no clinical symptoms, we did not give them glucocorticoid replacement at all in the perioperative period. We did start it if their basal cortisol was lower, they did not stimulate appropriately. So in our pilot study of 31 patients, 22 of whom had adrenal-dependent hypercortisolism, we found that 11 of those 22 patients had an abnormal stim test that we then had to start on glucocorticoids, but 11 of them did not. So 50% of our patients could and did go home without glucocorticoids, and none of them, most importantly, none of them required it after they went home. So we presented this at the AAES in 2014 with the conclusion that post-op day cosentropin stimulation testing is a reliable, reproducible measure for initiation of postoperative glucocorticoids. And I show this table just in the red box. just showing that there really was no difference in our glucocorticoid needing group and our non-glucocorticoid needing group in terms of their preoperative biochemicals. So it wasn't like we were looking at one set of patients who maybe didn't have a strong documentation of preoperative hypercortisolism. So we initiated that protocol at our institution. And similar to our calcium study, we said, well, is this still accurate, right? So, our volume is big enough that there was a bunch of us as surgeons doing it. So we needed to make sure that what we were doing was still accurate a few years later. So one of our fellows a couple of years ago reevaluated our experience, and then we looked at these 108 patients. And again, 54, almost exactly, 50% of our patients required glucocorticoid replacement. We also found that glucocorticoid replacement, because I think we got a little bit more aggressive about who we were maybe doing the skin testing in and not doing routine supplementation. Even patients with really overt hypercortisolism, about a quarter of those patients did not need glucocorticoid replacement, and almost 50% of the patients with mild autonomous cortisol disease. About 60% of our patients needed it for less than 3 months, which was great to know, and 80% needed it for less than a year. So we now have some better benchmarks for telling our patients how long we really needed postoperative steroids for. And the most important thing was that it was safe, right? None of these patients experienced life-threatening adrenal crisis, which is our biggest concern when we're sending patients home without glucocorticoids. And so our conclusion from this is, yeah, it's still an effective method, and we've continued this protocol. So how does this affect our patients in reality? What does this mean? So we had a 60-year-old woman who had a CT scan, a 3.5 centimeter left adrenal nodule. She, in purple on the right, you can see where she has pretty significant elevation of her salivary cortisol levels, and sequelae of hypercortisolism, perhaps. She had poorly controlled diabetes. And so she had an adrenal ectomy. And it was important for us to know that she did not require postoperative steroids, despite that degree of elevation of her salivary cortisol, which is great. But what we haven't really figured out is how can we predict who needs it or doesn't? Because now we have this other patient of mine, 47 years old, incidentally found adrenal nodules. You can see them on the left there. She had a really mildly, if at all, elevated cortisol of 2.2. Her salivary cortisols were a little bit more mild. She had adrenalectomy, and she did not stim at all. And so this was a patient who even the endocrinologist, called me afterwards. She's like, I can't believe that this patient needed steroids, given the body of work that we've looked at over the past few years. But she did need steroids, and she needed it for less than 3 months, but she did need some postoperative supplementation. So we haven't really yet refined who does or does not need it accurately, but we do know that approach to the postoperative post-interrupted stim testing does work. So about 2 years ago, the endocrinology group recruited a fellow who had trained at the Mayo Clinic, where they often do basal cortisol levels post-op day 1. And so when she got to our institution, she was like, well, that's great, but we just do basal cortisol levels, and we think that's better. And so now I was trying to convince a newly graduated fellow that our 10-year history and our really experienced endocrinologists, should we move to basal cortisol levels based on her experience? So we had a visiting resident visiting our endocrine surgery service for about a month, and so we set him on this task. And he presented this at the Endocrine Society meeting in 2023. And this was really recently just published in the Annals of Surgical Oncology. This is the visual abstract for the paper, where we then said, fine, we're going to look at the basal cortisol levels because we're getting them anyway in our post-interrupted stim test. We're going to do the whole test, and then let's look back at our data and see, okay, if we had just done the basal cortisol, who are we missing or who are we not missing that needed steroids? And so we looked through that. And what we found was at certain thresholds, there might be a point where basal cortisol could identify patients at risk for secondary adrenal deficiency and need for glucocorticoids, but there was a gap. So if you had a basal cortisol between like 5 and 10, there's a potential gap that you could be sent home without steroids and maybe need them. So we've stuck with our post-op day 1 post-interrupted stimulation testing as opposed to basal cortisol. But again, it's just a reminder to all of us that when we adopt new protocols or think about new protocols, to be flexible about it, to be willing to reevaluate where we stand with our protocols and think about what needs to be done. So going back to this question of how do we change what has always been done, I think it's important to look at the why, right? What is the history behind some of the protocols? Because some of the things that we do really have good data, even if it's from 50 years ago. We don't need to revisit it, but it's important to know what data it does exist. Consider what you might change, why you're changing it, and then how you're going to change it. And the most important part is to include the team. And so for us, this meant the surgical team, So when we did both our calcium, especially with the prospective study, including our surgeons, our fellows, our residents, all of our APP staff, including our endocrinologists, because we couldn't just all of a sudden change, how we were sending these patients home when they're so involved in their perioperative management, making sure our patient care teams understand when we need blood draws, why we need blood draws, and what we're doing around it, make sure that our lab team understood why we were doing it, and the most important, considering what effect this is going to have for the patient. Whether it's in the preoperative, perioperative, and especially the postoperative period in terms of their quality of the surgery that we're giving them and the quality of the care that we're giving them. And then as I've emphasized a few times already, be willing to reconsider your hypothesis and be flexible. And, eventually you get to the top. There might be a lot of suffering as you get there, but it can be really invigorating when you achieve your goals around that. I'm just going to spend the last few minutes talking a little bit about how some of this work led to some of the as I think about it, some of the things that have developed along my academic career. So, again, it seemed like a really, really pretty silly question, just this random question about postoperative hypocalcemia. But what the thyroid protocol led to was presentations at 3 regional and national meetings for our residents and our fellows, 6 peer-reviewed publications on protocol for calcium supplementation, and that resulted in invitations to review manuscripts and journals, which at that time as an early career surgeon was particularly meaningful for me, or invitations to do other reviews on the topic and book chapters and that type of thing. And again, as I was building my portfolio and my CV, those were all really important opportunities for me. It was gratifying that when we presented these data, so the prospective study on thyroidectomy, and then the initial study that we did on our protocol, a pilot study for the adrenalectomy, each of those went on to win the Best Clinical Research Award at the AES annual meeting. So one for one of our residents and then for our fellow. And so again, that's just a gratifying body of work, and for them to have some achievement in their own careers. And why does this all matter? Again, it establishes you as a clinical expert, and it starts to help you build a local and national reputation. So perhaps national reputation amongst surgeons, but locally it builds, if you're involving your endocrinologist in decision-making, you're disseminating your work, it allows them to see you as a local expert and someone who's really thoughtful about how you're managing their patients and your mutual patients. It also provides a really important platform for students, residents, fellows, and other early career faculty to be presenting, right? So some of this work I presented myself, some of it was our residents and fellows, but again, it led to us working together as a team as we were building our research program and allowed them to get in front of the podium at our national and regional meetings. And it really led to the foundation of us having a strong clinical research program. So there was a multidisciplinary effort to develop and disseminate each protocol. And it was really great to have an institutional knowledge of outcomes and discussion with patients. So when they ask, well, this has never happened to you, right? Because we all get asked that in clinic. You can say, well, we all know we have complications, but you have your own institutional, your own personal data to tell patients. So you can be, when you tell me that the risk of hypopara is X, you're really backing it up with your own local experience rather than just what you read, the international experience might be, or another group of surgeons' experience might be. From an adrenal perspective, building that clinical program was important because it led us to develop some institutional protocols for adrenal disease. So because we had this collaboration with our endocrinologists, we were also seen as we are seen as a relatively close group of multidisciplinary colleagues, which allowed us to have some leverage in developing a multidisciplinary adrenal clinic. So every other Friday, we have a multidisciplinary clinic in our cancer center, and also allowed us to work with our radiologists so there's some standard reporting. So now when a body CT is done and an adrenal nodule is incidentally identified, there is some standard reporting that they will put in to consider biochemical testing and or referral to our adrenal clinic, and it will also refer this to this algorithm. The link is provided in the body of the report that goes to this intranet site that shows sort of our current algorithm for the work of adrenal incidental tumors. And over, I think, the past 5 years that we've had this adrenal clinic, again, our volume has increased in those patients, and that allows kind of everybody in our community to know how intensely focused we are on this disease. It also led, similar to the, as I've mentioned, national presentations for our residents and fellows, both at surgery and multidisciplinary meetings, the body of work that we've done around adrenal disease, and there's other work that we've done that I didn't have time to talk about today, allowed our institution to be a founding member of A5, which is the American Australian Asian Adrenal Alliance. And so it's an international collaborative. And so there's, each group, there's many working groups. And so we're currently participating in a study on predictors of adrenal insufficiency. So there's 9 centers, I think they're all in the US, that submitted data. And we submitted data for almost 200 patients, which, when the PIs, kind of got that number of, oh my goodness, that's a lot. And so we were able to provide meaningful contributions to work outside of just our institution. And then institutionally, we just got a pilot grant for a CTSI ensemble. So we're working with endocrinology and our neurosurgery team to look at all of Cushing's disease and ACTH independent hypercortisolism. And so we're looking at a seat grant. We have a seat grant now to look at this prospectively and work together collaboratively to look at these patients. And what we're going to be doing is hopefully looking at the non-operative patients, which is collaborative, and this grant will allow us to do. And then we're also hosting a pituitary adrenal symposium amongst the department at the end of next winter. So it's given us a lot of opportunity to expand our footprint just beyond the day-to-day of what we do in our little world of endocrine surgery. So in conclusion, hopefully over this past 40 minutes or so, maybe you thought a little bit about the perioperative management of surgical endocrine disease. Some of you may actually care about that. Some of you may be like, I don't care what these endocrine surgeons do. All I talk about these little parathyroid glands. But I think what I hope to impart on you guys also is that clinical research can start with a very simple question. That comes from what we do every day. But it can have a meaningful impact if you're thoughtful about it on our patients and how we care about patients. It can have an impact on the relationships you build with the referring providers and the people that you work with at your institution. And hopefully will provide the foundation for professional development for yourself and the people you work with, and hopefully change some of what you do as a career path as well. So I'd like to thank you guys for the invitation to be here today. And for the opportunity to speak with you. This is our great group, the 4 of us who are our endocrine surgeons and our clinical EPP group back in Milwaukee. If you guys will visit us one time. Thank you.
We talked a little bit, as a question for you, we talked a little bit beforehand about what started as a quality project here. Dr. Hedrick, I don't think is here today, was looking at putting together an ERAS protocol, and I witnessed the moment where Rob Sawyer said, we're going to study this in course, which he hadn't been planning to do, which resulted in being very beneficial to her career building as well as ERAS probably being more widespread at the institution. I'm sure you've had things you've done as just practice changes or quality improvements, and not all of them result in studies. So there's a lot more effort and work that goes into studying, in addition to all the work it takes to change an existing dogma, getting everybody on board. So as you're looking at that decision point, how do you decide, well, this is one where we're going to, in addition to just trying to change our practice, we're also going to put in the work, this is worth the study, and it'll be valuable beyond just changing the practice.
Yeah, I mean, I think it's also around the culture of where you are and the idea, especially those of us who are here at academic centers, we have to publish still some of it. And again, it's one of those things where you don't think, right? Like some of this stuff doesn't seem like anyone else would be interested. But it was fascinating to see, when you present this work, how many people are like, oh, that's really interesting. We've never looked at our data, or this, it's a great idea to have looked at it and published it and thought about it. And there's always, there's also other things that we've done where, we published it. We didn't present it necessarily. We got it published. And you'll get a random email where they're like, something happened and I was looking it up and then I saw your paper and that was really helpful. So there's always impacts that I think you don't always necessarily know that someone's going to pull up your paper from PubMed and do that. And I think there's a culture around, Doug Evans has always instilled in us, if you're going to do something or change something, write about it, right? Because that's our current academic currency and that's important. We might not be in the highest impact journal all the time, but again, it's that habit of writing too that gets you into the habit of writing that allows you to think about it for other projects and other things. Because I think especially for some of our students and residents, it's a hard, writing and doing research is a hard thing. It's conceptual. It's like, oh God, that seems like so hard. But if you start doing it a little bit at a time, then it becomes easier and it becomes more natural to do.
So this might be a bit of an odd question, but I'm going to ask, what motivates you? And what do I mean by that? Like, it feels, as I've gone through my career, there are some generational differences. And, what motivates somebody that's almost 60 was different than what motivates someone who's 40, what motivates somebody who's 20. And how do we, there's a lot, like, how did you find the time to do this? What was your goal? Was it to become famous? Was it to become rich? Was it to become a professor? Was it to do a lot of cases? Because most of this was done on your own time on weekends, I suspect, right?
Yeah.
And which meant it took away from your family and it took away from this. And so how do we decide where the value is and how do we measure that? And as you kind of reflect back on your career, what sacrifices did you make that seemed valuable to you, and maybe were some sacrifices that you made that you think, well, geez, that was a waste of my time. And how do we figure that out?
Well, that's a really simple question to answer now.
Yeah.
So, thinking about this, and one of the things that I think, what motivated me at this time, so some of it was I didn't even think beyond like the single thing at the time. Like there is no grand plan around any of this. It wasn't like, oh, if we do this study now, in 5 years we can do the follow-up and any of that. So some of it, I think, as I think about my career, was just incidental, just little steps. And we're like, oh, let's just kind of look at this. Or, Tina Yan was one of my partners for a long time. It was mostly her and I. Our offices were next to each other. We would just kind of free-form talk about some other stuff. One of the, I think, the interesting things, and as you were asking the question, is also the role. So in my academic career, right? So one of the things that I think about is that none of this was funded. It was, as I mentioned earlier, it was incredibly hard to get funded for this type of thing, even some local state grants. And in my career, right, I've never had external funding as a researcher. And so there's thinking about clinical research and building a body of work for which, you are going to be externally funded, and do that. And maybe that motivates people. For one reason or another, that was never a point of emphasis in my career as we were doing some of this stuff. And so for me, as I think back on it, there's certainly some decisional regret that I wasn't more aggressive about some of these things, maybe being more intentional about that. And I think about that at this point because now, as I am later mid-career or maybe even more senior career, I don't know, and I think about what the next 10 or 15 years of my career looks like, I'm like, okay, do I want to maintain the clinical volume, what else interests me, right, and motivates me to continue doing what I do? Would funding have helped me in a different way? So there's a lot of questions I have about my career. I don't think there is an easy answer to think about what motivated me. It certainly wasn't like, oh, if I can publish this, I'll get to be X, Y, or Z. I think some of it was inherent in myself and just being like, I'm just going to be a good steward of being, an academic surgeon and publish a bunch, see how we can mentor some residents and students to publish, and kind of be on that track. I don't know if that makes sense. I will say that in the arc of my career, I think every 7 or 8 years, I get a little antsy and think about, and I've been at MCW for 17 years, so, I have had a great career there. But I've been fortunate to be able to evolve my career in other ways. So while we're maintaining this clinical work, a lot of it in the past 5 or 6 years for me has shifted where Sophie Dream, one of our, I think we hired about 5 years ago, she became a section chief of endocrine surgeons. So she does a lot more of the day-to-day clinical stuff. And I've been working a lot in our department around professional development and other things. So even in my own career, like this is still what I'm clinically passionate about, but I have found other outlets for some of my own, what has evolved in my career about what motivates me and what impact I want to have at the department level or at the national level. So, Alan and I are both very involved, Dr. Sun and I are both very involved in SAT. And that's one of the things that I couldn't have predicted didn't exist when I started my career as an organization, but it's been really impactful. And so there's other avenues that has motivated me as a professional. So I think just being open to those opportunities as you evolve your career and realize that things are going to evolve, you have to take advantage of those opportunities as they come up.
Dr. Wang? Thank you. Thank you so much.
Know all of the background on all the things that I did.
They really nailed it.
And they were calling, yeah. Sorry, guys.
Fine.
I just like. I just thought it was. I thought about that. Oh my God. I need her in all the days to have a last one.
Oh, maybe they didn't know. Yeah, that's great.
How are you?
I'm talking about, you want me to talk about innovation.
I like to remember, bring a little Lisa to this experience today. Hey, morning. Good morning.
A video of like laparoscopic, what it looks like for hernia repair, and it's like, you know, and the video is like beautiful.
Curtis Smith?
That's like
I got it.
Phillips.
Sorry I couldn't make it last night. We were stuck here till almost 8 o'clock.
Yeah. Yeah, no worries. I didn't see your emails until later. You want to be Ellen is.
Oh, no. Okay. I'm sure I can take her some coffee.
Honestly, I don't think she has anything else on her schedule until.
Hey, I'm Tina Fashani. I haven't met you. Hi. Pleasure to meet you.
Yeah. Are we gonna just, and in clinic when it is time?
I mean, essentially, we want to be.
Yeah.
But it should work out fine. Okay.
Sorry, I'll leave.
Let me check.
Oh my goodness. And that's like,
But it's so big.
oh God, I can
Yes.
imagine. Yeah.
Anyway. We don't have a plan for that exactly, but,
You want to keep it in my office? Or in your office? Or-
so, like
What's
I
the
said,
plan?
so really, the only, and Alan seems to be not around unless
You
he
didn't
services.
respond.
Yeah, I haven't. Hey, I hope it's okay.
Want to keep it in our office. Because you're going to clinic.
Yeah.
Okay. She had niece.
The only thing that we actually have then was a meeting with Alan, which the only thing actually scheduled other than lunch with us. So whatever works for you, wherever where you're gonna be picked up by the car is actually closer to my office.
Okay.
So I can take that to my office and then you can, once you have stuff that you want to.
I'll just in my bag.
Okay. All right. I'll take that to my office. You guys can,
Are you coffee?
Yeah, perfect.
Okay.
Great.
perfect.
All right, and then I'll catch up with you.
I'll
on
Yeah,
lunch.
come up
just
and
text
I'll
me,
find it.
Well, you text me or
So after
Afterwards.
coffee, what do you want?
whatever you best think, what do you want to do?
I
Like
don't
you
know,
want
it
sort
said-
of hang out?
yeah, it's a conference room.
Yeah, the conference room's reserved and available. You
Yeah,
guys
I'll go there.
okay, good. But you like, would need help finding that.
Fishing.
I can have Mary. Do you have Mary's number from Mary Sims on that?
If you send me an email.
Mary Sims, 434-825-6954.
Yeah, so I'll actually put this in that conference room then.
Okay, perfect.
And then she can help you find that.
Yeah, I'll just text Mary.
Perfect, good. And then I'll let you know when we're ready to run that. Which will be reasonable,
Okay.
everybody agrees.
Sounds
I'll get
good.
this there.
Thank you.
Perfect, good plan.
How are you?
Good.
Nice talk.
Patty actually knows that. You know that? No. You know the character from Scrubs? Scrubs?
Oh, I'm aware.
Yeah. I never watched it either. So the black character. The other guy. But I didn't know. I didn't start. So I was like Googling like pure character TV and it researched it. I came up with it. So that how like how did this how did
It's much work, isn't it? Oh my God.
yeah.
I don't think what happened now. And then this great balance. I don't know if Brady went for it. And also, what the.
It does have, it does come to cost.
It does come.
And I would, I'm a little bit, impression, but I'm a little bit biased, and I feel like the primary motivator for most, probably 90% of people, is personal career, and that's it. Is that too cynical?
No, it's 100% accurate. I mean,
I'm papers for her.
no, it's 100%. I mean, I think it's even getting worse. I think, but, and I'm a prime example.
Sorry.
I mean, I can't say that. I'm almost
These
sometimes-
floors are disgusting. Don't they clean in here?
They really need to at least Swiffer it.
They're
and I'm
getting
actually not-
worse and worse. It's like nobody cleans in here.
Appreciate it.
I hate to have them the same old food.
Motivated by this, like literally fear of failure. I didn't want to like.
That would be what I would say.
People picking up used masks and snot rags. Oh, I wouldn't touch that. Ugh, you kind of have to.
Oh, no. My teaching, bloodborne pathogen, you don't touch any liquid.
There's a
No
cup
bodily fluid.
down there.
Where? Okay.
I don't think it's clean in here.
No.
I wonder who takes care of this place.
I feel bad. Well, I didn't even think her.
What's she talking about? Oh,
And I told her, she's crying.
I didn't even realize that.
And I told her like 6 times.
Yeah.
I have nothing.
I mean, maybe
She was junior.
Autumn's doing it.
And Autumn was like,
But nevertheless, but the this is the part that works. I guess I'm guilty of it too. Like, and the dude that I'm with, both said, you got, we, like, this is the key to get medical students to get a residency. Yeah. And it's pathetic. Now, part of the problem is, you know, what we've done, we had a, chapter meeting. I was in charge of picking the speakers.
Very rarely, and I,
One guy.
I love Brian. I was your husband, that's for.
Oh, you know Brian?
Yeah.
Oh, yeah, right. Because, so, and I forgot he was a student. So, so
That's so smart.
I emailed, and I looked at him. That's all. Stuff. Yeah. I found it very fun.
And all the testing and stuff like that. Oh, he posted some of the questions, and it's like, I want all the candidates to see if they can answer these questions. They're so ridiculous.
But so I invited him to come speak, and,
he would talk. And I forgot him. I mean, I knew he didn't yet. And today, I forgot. Like, you were my third, but he never. But so we had some nice things back and forth. And then he gave a really great talk about decline of residency here and all that. And you know, started that. He's also great. Yeah, so, you know, he quote, unquote, little intimidated. Are you walking an hour? So he,